I am Carrie Ann Savard, and I am presenting today on the failure to fail phenomenon. This topic is imperative to nursing education, as the failure to fail unsafe or incompetent student nurses not only jeopardizes patient safety, but has implications for students, nurse educators, and healthcare organizations. To begin this presentation, we will first review the learning objectives. By the end of the presentation, the learner will identify contributing factors that lead to failure to fail by nurse educators and mentors, understand the consequences that failure to fail has on nurse educators, mentors, healthcare organizations, and nursing students, discuss theoretical frameworks related to the failure to fail phenomenon, and lastly, implement solutions that reduce the incidence of failure to fail in nursing education. Next, we will discuss the concept of failure to fail. The primary role of the nurse mentor is not only to support the professional development of students, but also to prevent failing students from becoming registered nurses to safeguard the public from incompetent practitioners. The phenomenon of failure to fail is to pass a student who does not display satisfactory clinical performance. It has been identified that practicing nurses are concerned that students can pass assessments of competencies, but not be competent in fundamental nursing skills. If this is indeed the case, there is of significant concern, as when a student achieves an accredited nursing qualification, they are deemed competent to perform an acceptable professional and university standard. Without competence, the safety of patients is at risk. The prevalence of failure to fail. The literature delineates evaluation of clinical students as one of the most significant challenges for nurse educators and mentors. The prevalence of failure to fail varies among the literature, but the phenomenon was initially drawn to the profession's attention in 1990. This may be due to the fact that nurse mentors would have to admit the struggles they'd had with students and admit that they passed a student who did not meet expectations. Despite prominence in the literature over the last 30 years, failure to fail is still a concern today. As evidenced in the presentation, the number of mentors and educators admitting to failure to fail ranges from 18 to 43% as reported in various studies. Though the prevalence of failure to fail is hard to ascertain, the risk to the public is certainly high enough that reconciliation of this problem is warranted. Next, we will review factors that contribute to the failure to fail phenomenon. Assessment of clinical competency may appear straightforward, but it is a complex process. It is based on the direct observations and therefore involves value judgments which are subjective and can vary from person to person. Therefore, one mentor may pass a student while another mentor may fail the same student when assessing the same competency. The registered nurse is expected to use a combination of attributes, including knowledge, skills, values, and behaviors, to ensure that the development of competent practitioners takes place. However, the role of the mentor is often complicated by having to balance the assessment process with everyday duties, such as delivering patient care. The implication of this is that the continuity of the student assessments is often broken and not seen as a priority. The literature reveals many contributing factors to the concept of failure to fail, the first being difficulty feeling a student. Many educators and mentors find feeling a student a very difficult process. The literature suggests that upon reflection, many mentors question their own competence, the quality of mentorship provided, and whether their judgment to fail a student was correct. They often question if their standards were too high for the student or if they were being too harsh and fear being labeled a bad nurse. Mentors also display genuine concern for the student, particularly in light of the impact the decision to fail would have on the student's life and career prospects. In addition, when deciding to fail a student, mentors felt it would be difficult to prove their concerns and often consider the time and financial investments made by the student as reasons not to fail them. The additional duties and time required when failing a student also led to physical manifestations for mentors, including sleepless nights, exhaustion, and effects on general functioning. Lack of confidence. One of the strongest contributing factors causing a mentor to inflate a grade, thereby passing a substandard student, is lack of mentor confidence. Strong, experienced clinical nurses, though experts in their field, are often novice clinical instructors. Most nurse mentors receive no formal training in the complex subjective grading criterion in which they must abide by to pass or fail their student. A report by Hodge et al. In 2019 reports that 43% of mentors state they felt insufficiently prepared for their role when faced with failing a student and were uncertain what or how to document. Nurses who mentor students require training in assessment and evaluation tools, providing feedback and giving constructive criticism to increase their self-confidence in their ability to accurately assess a student's competence. The emotional process for nurse mentors. Failing a student is a difficult, emotionally burdensome process. In addition, failing students is sometimes believed to be an uncaring practice because for nurses, caring is a fundamental principle. Therefore, having to face a student with the reality that they will not progress is a very emotionally difficult process for the mentor. Nurse mentors and educators also face feelings of stress, anxiety, anger, guilt, and sadness when facing a failing student. This is because they genuinely have concern for the student and empathize with them. They understand that deciding to fail a student involves having a difficult conversation that could potentially cause them emotional harm. The students may also react negatively to feedback with anger, manipulation, or even violence. Workload and time constraints. In a profession strapped with time constraints and heavy workloads, the extra role and duties that come with mentoring a student further add strain to the system. When working with a struggling student, the investment time-wise is exponentially more than with a successful student. The literature suggests that a reason why mentors decide not to fail a student is because there is a lack of time to document a failing student. As reported by Bachman et al. In 2019, mentors often decided against failing a student because they were not familiar with the formal procedure and felt it was difficult to prioritize mentoring in addition to clinical tasks. The lack of university support. As reported by Doherty and Dykeman in 2015, almost 20% of nurse mentors felt unsupported by course coordinators in their decision to fail a student. There was also a perception of pressure from administration, who had the ability to overturn grades, pressure to not fail students in the later stages of the program, and pressure to conform to grading norms. The literature also suggested that many mentors had concerns that nursing management would not support their decision to fail the student. In addition, students have the ability to appeal the failing grade and have the decision to fail overturned. This causes nurse mentors to lose confidence, feel betrayed and devalued, and often refuse mentoring students in the future. The final theme to be discussed regarding failure to fail is giving students the benefit of the doubt. A common phenomenon of failure to fail is giving students the benefit of the doubt. The literature reports that with time, nurse educators felt that students could do better. As cited by Bachman et al. In 2019, some nurse mentors stated the student had not gone so far as to put the patient's lives at risk and had therefore given the student the benefit of the doubt and passed. As patient safety is much more than simply putting a patient's life at risk, this exemplifies the need for universities to put forth clear standards in the field of safe and unsafe clinical practice. The literature also suggested that oftentimes the benefit of the doubt is given more easily during students in earlier years of the program, with decreasing tolerance as the years progress. By giving students the benefit of the doubt, it does not provide students with opportunities to remediate actions, behaviors, or attitudes early in the program, which puts them at higher risk of failing in their last year. Furthermore, if a student is given the benefit of the doubt and passed when they do not meet expected competencies, public safety is threatened. Ultimately, then, the benefit of the doubt is a failure on the professional mentor's role to protect patients from harm. Consequences of failure to fail. Failing to fail nursing students who do not display satisfactory clinical performance can have significant implications for individual students, assessors, nursing professionalism, and patient safety. Students. Competence in nursing is vital for safe practice and maintaining a high proficiency. Improving quality of care is the overall aim of nursing, and central to this is the prevention of unsafe practice and improvement of patient safety. According to Luanga et al. In 2014, unsafe practices include a student's act or behavior that reflects a lack of knowledge, skills, or clinical judgment, or any unprofessional or unethical conduct that threatens or has the potential to threaten the physical, emotional, mental, or environmental safety of the client, self, or other healthcare personnel. When a student engages in unsafe practice, it can result in medication errors, adverse patient outcomes, and patient mortality. In addition, incompetent nursing practice can lead to professional misconduct and disciplinary proceedings, and the nurse is at risk of losing their ability to practice. Therefore, the ability to properly assess students' competence is essential for nurse mentors and educators. Consequences for nurse educators and mentors. Nurse mentors, faculty advisors, and university faculty members have an academic and professional responsibility to teach, supervise, and evaluate students' clinical performance and to ensure that the graduates of their program are competent to practice. Part of this responsibility includes assigning a failing grade to students who have not demonstrated the required level of competence. In addition, allowing a student who does not meet practice standards to progress in a nursing program can be seen as a breach of ethical responsibility and professional credibility. Failure to fail can place the faculty member and educational institution in a legally liable situation, and the faculty member can be sued by the student. Faculty members have a duty to ensure that only students with the appropriate knowledge, skills, and values to serve clients are allowed to graduate from educational programs and to be admitted to a profession, thereby protecting society from incompetent or unsafe practitioners. Professionalism. Professional, legislative, and community expectations mandate that nursing graduates are well prepared and capable of providing safe and proficient patient care. Failure to fail incompetent students can be detrimental to educational programs and the professional standard. This can limit educational institutions' feedback on performance and jeopardize the effectiveness of assessment system and can put reputation of the institution at risk. Ultimately, it is our professional and ethical responsibility to report unsafe practice, and this begins by identifying those who do not meet up to professional, competent expectations. Patient safety. As previously mentioned, failure to fail incompetent students does not protect the interests of the public and clients. Unsafe practices can have serious consequences for the health and well-being of the public. This can lead to medication errors, adverse patient outcomes, and patient safety concerns, and put patients' lives at risk. As our main goal of nursing is to protect our patients, it is imperative for nurse educators and mentors to enact changes to decrease the incidence of failure to fail. Next, we will discuss theoretical frameworks related to the failure to fail phenomenon. The first theoretical framework that we will discuss is the invitational theory. The invitational theory was first introduced by William Perky in 1992. The theory has three assumptions: that students are capable to self-direct, the process is just as important as the outcome, and that learners have unlimited potential, thus learning environments must allow fulfillment of potential. The theory also consists of 5 domains, including people, places, policies, programs, and processes. In relation to failure to fail, this theory could elucidate an understanding of assessors' experiences of grading nursing students' performances in clinical courses when that performance is not a clear pass or fail. In reference to the people domain, people are central to the phenomenon of failure to fail, as it is the people that create and maintain the invitational environment. People will flourish when the core elements, care, trust, optimism, and intentionality of the invitational theory are present in all interactions. Processes. Oftentimes, the processes involved in managing and feeling performances that are not fit for practice are inconsistent. Intentional invitations through processes enable people to achieve their full potential. Programs. The invitational theory advocates that programs should be designed to enhance personal and professional growth and development of all stakeholders in the environment. Assessments and program designs need to be innovative to ensure that standards of practice are met, yet key stakeholders are supported to enable their true potential to come forth. Policies. Policies must be enforced consistently and fairly. It is vital that policy and policy making must respect people and their needs, which provide mutual support to both the learner and the assessor and the learning community. Places. Places need to be welcoming and inclusive so that both learners and assessors feel a sense of ownership and belonging. If the environment where assessments occur is not conducive to learning, then this may have an impact on assessment outcomes and potentially failure to fail. As we can see, each domain is interwoven with another, and only an interwoven multimodal approach will see improvements in mitigating failure to fail. Benner's novice to expert theory. The novice to expert theory was introduced by Benner in 1982. This theory suggests that nurses develop skills over time from education, clinical learning, and personal experience. Benner's model discusses 5 levels of nursing experience as a nurse progresses throughout their career. These include novice, advanced beginner, competent, proficient, and expert. As mentioned previously, a nurse may be an expert in their field, but may have to move backward in the model when performing new roles. For example, a clinical expert moving back into a novice educator role involves the novice expert cycle starting over in this transition, as they are now adjusting to different skills and knowledge and will advance over time. Therefore, it is essential for novice nurse educators to receive additional education and support when entering a new role. In addition, clinical learning experiences allow nursing students to increase their knowledge and skills, allowing them to move from a novice, entry-level student to a competent individual who can ensure the safety of those they care for. It is imperative that nurse educators and mentors properly assess students and provide them with opportunities to increase their competence prior to assigning them a passing grade. Proper assessments, education, and training for both students and mentors can help decrease the incidence of failure to fail. The Nurse Educator Transition Model. The Nurse Educator Transition Model was developed by Schoening in 2013. This theory suggests that novice educators receive little formal preparation for their teaching role. The model consists of 4 phases in the transition to nursing faculty. In the anticipation expectation phase, novice educators expect a lifestyle to be flexible. There is an opportunity for career progression, has positive student encounters, and the nurse wants to make a difference in teaching students. In the second phase, the nurse faces role ambiguity and feels a lack of mentorship. The lack of orientation can be overwhelming, especially when learning a new skill and knowledge set. In the third phase, the novice educator will seek more information to help the transition, such as faculty development programs and using more mentor assistance. This leads to the 4th phase, in which the novice educator will start to establish more boundaries, become more confident, accept more responsibilities, and develop comfort in the student-teacher relationship. This theory highlights the importance of education and training for novice nurse educators. Providing educators with staff development opportunities, a well-structured orientation and mentorship program will help support clinical nurses transition into assessor roles. Supporting new clinical nurses will help them attain the necessary skills to properly assess and recognize students who are unsafe or do not meet expected competencies and standards. The ability to recognize these students can help decrease the incidence of failure to fail. Now that we have a better understanding of the theoretical frameworks related to failure to fail, we will discuss solutions to help nurse educators and mentors during this difficult process. There are a variety of strategies or approaches that can be implemented to facilitate student success and manage students who are unsafe or incompetent and at risk of failing. The first solution is to incorporate failure within nursing curricula. Within clinical learning programs, students face the possibility of failure. As suggested by Law and Finnegan in 2021, failure should be incorporated into nursing pedagogy, which includes best practices for instructors to support students through a failure experience. The instructor should focus on teaching students to adapt and use their existing knowledge during a failure experience. When students accept failure as a possibility, it makes them more willing to act despite the possibility of failure and better able to learn from their experiences. In addition, introducing failure at the beginning of the program should lay a foundation for later building skills related to flexibility and adaptability. Tools like contingency planning and open discussions about experiences of failure can help build a flexible growth mindset. Another important solution is early recognition of a struggling student. Signs of possible failure are often apparent from early on in the clinical placement. These often include students not asking questions, having an unenthusiastic attitude towards nursing, and demonstrating unsatisfactory skill performance. The ability to recognize these early signs is important for nurse educators to uphold their commitment to the safe patient care and to ensure strict nursing standards are upheld when allowing a student to progress. Nurse educators should ensure students are evaluated early, accurately, and fair assessments are being made. This provides students with the opportunity to remediate practice issues and increase their chances of success. Reflection and debriefing. Reflection and debriefing are important for both students and nurse educators when faced with a failure situation. With regards to students, when there is a problem identified, it should be immediately communicated to the student. This provides the student an opportunity to reflect on the issue and identify the factors contributing to the problem. When students self-reflect, it contributes to increased clinical skills, enhances critical thinking, and assists in correcting mistakes. This gives the student the opportunity to understand their strengths and weaknesses and change their practice to be successful in the future. For nurse educators and mentors, the decision to fail a student is emotionally difficult. Educators can use self-reflection as a tool to objectively reflect on previous situations of failure. In addition, debriefing can also be utilized as a supportive tool for nurse educators as failing a student is stressful and emotionally challenging. Education and training. Valid and accurate evaluation of students' clinical performance is crucial to ensure they attain their educational objectives in their professional training. Evaluation in clinical placements is seen as one of the most challenging and stressful aspects of teaching. If there is a lack of understanding about the assessment tools, the mentor may not know what they should be assessing. Therefore, it is imperative to provide education on evaluation assessments, tools, and practice appraisal competencies such that accurate student assessments are made. Additional solutions for increasing education for mentors is to provide certification programs. This can be done in the form of online courses, in-person training, or e-learnings that mentors can complete at home. This would address mentor confidence by providing the mentor with the training and support required to identify and address a failing student. Goal development. The need for ongoing feedback is essential in the assessment process. It provides a mechanism for the student's practice to be regularly monitored and discussed. Repeated feedback enables both the mentor and student to identify areas that are improving and areas that are weak. This can include the development of SMART goals, goals that are specific, measurable, attainable, realistic, and timely, or through providing the student with a learning plan. The student should be given a timeline of when to complete the agreed upon goals. When this occurs, there is a clear understanding between the student and mentor that if goals are not met, they will not receive a passing grade. This would help to decrease the incidence of failure to fail. Finally, the last solution is increased support. Both university faculty and administrators in the clinical setting need to acknowledge the emotions and stress associated with the decision to fail a student and ensure that supporting mechanisms are available to all those involved. Recognition and additional resources are required to compensate the extra workload that occurs with mentoring students. This includes providing support with documentation to ensure that the mentor has a clear, well-evidenced report that not only supports the mentor's decision-making process, but it also allows the student some protection against the irresponsible decision to fail. Mentors and educators also need to be supported through their decision to fail underperforming students and not fear their decisions will be overturned. Nurse educators also need to support assigned mentors in the clinical areas. This can be accomplished by mentoring the placement of students, conducting regular meetings, visiting the site, and keeping in contact through phone or email. To avoid the issues that arise from the failure to fail underperforming students, university faculty members and clinical educators require support in their decisions to fail students during clinical placements. In conclusion, failure to fail is still a concern in nursing education today. When educators fail to fail students who do not meet educational requirements, patient safety is jeopardized. It is a nurse's professional duty to safeguard the public and to report on safe nursing practices. The contributing factors, theoretical frameworks, and solutions were provided within the presentation. To sum it up, the decision to fail a student in a professional program is difficult, rife with consequences, and not taken lightly. Such decisions should be made only after consideration of the consequences to the student, clinical educators, the public, and professional programs, and the integrity of the profession and the university. It is important to ensure that registered nurses are supported in their role as clinical educators and are able to guide and facilitate the learning of students as to decrease the incidence of failure to fail. Thank you.